Yeah, Sudhakar. Yeah, Sudhakar, you could start your sharing your screen. You'll have to unmute yourself. Please unmute yourself.
Should be able to see my screen now.
Yes, yes.
Thank you. Thank you all. Thank you for the kind introduction, Dr. Kavita and Ishwar. I feel privileged, honored, as well as humbled by this opportunity, especially for this webinar, which is being conducted in the name of the Professor Kakala, the wise man who, in his own words, sometimes back when he was talking about his career, how he has actually saw his career into three parts. First 30 years he has spent in learning radiology with hard work, sincerity, and the second 30 years earning with that experience, and third 30 years he always said that it was a bonus, and he could actually see in giving back it to the society. And it's a privilege actually for me to present this talk on his named seminars. Coming to my topic, clinical and radiological aspects of multiple sclerosis. So I work in Princess Alexandra Hospital at Harlow, which is a town a little north of London. And that's my hospital. And Harlow is a town, actually, most of you people may not know that it is the birthplace of the fiber optics invented by Sir Charles Cow, who was actually given a Nobel Prize for this in 2009. He is the father of optics, and he's also considered the godfather of the fiber optics. Actually, in one way, he is the reason for all of us being connected through these broadbands nowadays. So my talk will include, it briefly covers etiology, pathology, and risk factors, and followed by some diagnostic criteria, and some imaging findings of the multiple sclerosis and its variants, disease modifying treatments, protocols, and practical problems, what we envisage while doing MRs, and some take-home messages. So 40-year-old, this is an MR of an young person with multiple white spots. So what is it? Is MS the most likely diagnosis? In general, that is the concept for a long time, but that is a myth, just like the future King of England showing his middle finger. The fact is actually announcing his third child. So the fact in this case is also actually the prevalence of white matter lesions in young patients is nearly 5 to 10% when you take the age group of 20 to 40 years. This is especially true when it is when they're in the frontal area, multiple, tiny, 3 millimeter or so, subcortical in location, which have a very weak association with vascular risk factors. And more importantly, these are quite commonly seen in patients with migraine. For example, in patients with headache, nearly 50% of the patients, majority of the patients will have white spots in the white matter. Coming to the wide differential of white matter lesions in the brain, the multiple sclerosis, this is the list, and we are just concerned about the multiple sclerosis today. It is multiple sclerosis is a chronic inflammatory condition. We all know that, and it's a demyelinating disease, which will lead to considerable amount of neurodegeneration if it hasn't been treated properly. It is a disease of the central nervous system, that is gray and white matter. So involvement of gray matter has been proven beyond doubt now, and it involves the brain, spinal cord, and optic nerves. Just to remind you that optic nerves are not actual real nerves, but a part of the central nervous system. This is the most common neurological disease of the adults, and it unfairly affects the fair sex, women being 3 times more common than men. And the common age group it involves is 2nd to 4th decades. There are nearly 2.3 million estimated cases all over the world. And prompt diagnosis is important to treat it early so that you have the best results as far as the prognosis is concerned. The best part of imaging is that MR has got the best positive predictive value of all the tests that we can think of in MS. Coming to the etiology, this is an autoimmune. So your own T cells, the patient's own T cells actually act against the myelin, crossing the broken blood-brain barrier and attack the myelin, causing inflammation, demyelination, gliosis, and axonal loss. Just like many diseases in medicine, the current hypothesis or the theories nowadays is that usually most of the people are genetically predisposed and an environmental factor will trigger. So it is true for multiple sclerosis also. This is a gene that has been implicated. So these are the genetically vulnerable people who have this gene. And there will be an environmental trigger which will probably bring out the disease in this genetically vulnerable people. The risk factors that have been implicated is, the most important is the EBV infection. There was a huge study, there was a big study from Chan Public School of Medicine, Harvard University, where they have actually followed nearly 100,000 soldiers in US Army and found that those who are affected with Epstein-Barr virus infection at a young age have a 30-fold increase. There's a 30-fold increase in the incidence of multiple sclerosis in those compared to those who are not infected with EBV. And low vitamin D is also a risk factor. If you see that the prevalence increases as you move away from the equator, the colder climates, northern regions where the sunlight is restricted with low vitamin D levels. And smoking is an important risk factor worsening the disease. Luckily, MS is not racist, as generally people think that it affects the Caucasians more common than the non-Caucasians. But if you look at the history, if you look at the studies, both Caucasians and non-Caucasians who were born and brought up in Northern Europe have this equal prevalence or incidence and equal risk of acquiring the multiple sclerosis. This is all depends on the age of migration, it seems. Those who have migrated below the age of 15 will acquire the new region's risk of developing MS, whereas if somebody has migrated after 15 years, they retain the risk of their own home country. Pregnancy is considered to be protective. Remissions have been seen in 3rd trimester, and overall pregnancy reduces or lowers the woman's risk of developing MS. There was a study from Australia where which showed that women with 1 child is 50%, they're 50% less risk of developing MS, whereas women with 2 or more children, there is greater risk reduction. These are the varied symptoms and signs of multiple sclerosis, reflecting various areas of involvement of central nervous system. So nothing is spared actually. So all these symptoms and signs reflect the area of involvement. I would like to draw your attention to these two, the Lermity sign and the Etos phenomenon. Lermity sign has been classically described in MS, where the patient might feel a shock-like sensation from neck down the spine, radiating into the arms and legs. And Etos phenomenon is something like the patient experiences increased symptoms when they are exposed to heat, especially after a hot shower or after a workout. The diagnosis of MS is purely clinical. There is no pathognomonic clinical or lab or imaging findings. There is no definitive or 100% biomarker for the disease. So the diagnosis is mainly clinical, mainly based on weighing the factors that support the diagnosis on one hand with the factors that fail to support the diagnosis, or the factors that point to an alternative diagnosis. So neurologists will make the diagnosis, radiologists will never. The central theme of diagnostic criteria that has been followed has actually was proposed by Schumacher in 1965. So there are 3 dimensions to this. One is central nervous system lesions, which are disseminated in space, that is different areas of the central nervous system are affected, and they're disseminated in time, that is they're affected at different points of time. So these 2 are the important criteria, and the most important criteria is elimination of the alternative diagnosis, which is the responsibility of the clinician. McDonald's criteria actually worked on this, and they tried to simplify the criteria for for dissemination in space and dissemination in time. It was first proposed in 2001, and MR was included in the diagnostic criteria at that time. So it evolved over time, and the current criteria are from 2017, where oligoclonal bands have been included in the criteria. And probably during the next revision, it is envisaged that optic neuritis, and there are 2 signs on MR. I'll dealt with them later. Probably these also could be included. What does it consider McDonald's criteria? There are 3 points. One is clinical. That is neurological symptoms lasting for 24 hours. That's called a clinical attack. And at least there should be 2 clinical attacks, which were separated by 30 days. So these are the clinical criteria. And MR criteria for dissemination in time and space. I'll deal with that in the next slide. And of course, the oligoclonal bands also. So according to the revised criteria, the dissemination in space on MR can be found by these sort of lesions. If you see, these are the typical locations for the lesions: cortical and juxtacortical white matter, or a periventricular white matter lesions, infratentorial, and spinal cord. These are the 4 classical sites. So we should be able to demonstrate at least 1 lesion in at least 2 or more sites. So that will satisfy the criteria for dissemination in space. And dissemination in time, so you have to show that these lesions have occurred at different times. So if you have successive MRs, if there is a new T2 lesion compared to the first MR on the follow-up, that shows that the 2 lesions have occurred at different times. So that satisfies criteria for dissemination in time. Or else on the follow-up MR, if you see a enhancing lesion, that is an active lesion. So that also tells that satisfies the criteria. Or there's only 1 MR that was done at the time of initial clinical attack, but it showed non-enhancing lesions, which were old, and an enhancing lesion, which is acute. So that also satisfies the dissemination in time criteria. If dissemination in space has been proved by clinical or radiological criteria, then if a CSF oligoclonal bands are increased, then that also satisfies the criteria for dissemination in time. You don't need to wait for another clinical attack, or you don't need to wait for MR to show a new lesion. The role of MR, it's mainly to support the diagnosis, not to definitely make a diagnosis, and to assess the disease severity and activity, to monitor the response, whether the patient is doing well with the treatment or not, or is he doing stable, is he being stable on treatment, and while he's on treatment, to detect any adverse effects of treatment. MR is the one which actually answers that query. Coming to the typical locations in the central nervous system, these are the areas: brain, posterior fossa, and spinal cord. I'll explain you each in the next part of the talk. The lesions in the brain, as I told, the classical locations are juxtacortical or cortical, periventricular, or callosocaptal. If you see these 3 lesions, all of them are close to the CSF surfaces. So MS loves to stay close to the CSF surfaces always, not centrally. And the 4th lesion in the brain, which is pretty characteristic, is when it involves the inferior temporal lobes. What is a juxtacortical lesion? So basically, there should not be any gap between the cortex and the lesion. There should not be any white matter in between that. So that is the classical juxtacortical lesion. If you can see that, it is just following the subcortical U fibers. This is another involving the subcortical U fibers and the cortex. Another juxtacortical lesion. This is not a juxtacortical lesion. This is a subcortical lesion. You can see that this is a juxtacortical lesion. This is a juxtacortical lesion. Another juxtacortical lesion. This is subcortical. This is not classical again. So these are all green flags. This lesion is not touching the cortex. This is also not touching the cortex. This is away from the cortex and ventricle. So these are subcortical. These are red flags. These cannot be considered as typical locations for demyelinations. Of course, these demyelination can occur in these areas also, but these are not the typical locations. Periventricular lesions. You can call them as juxtaventricular lesions also. Again, they should abut the ependymal surface. For example, this is a classical periventricular lesion. This is not. This is another periventricular lesion. You can see periventricular lesion adjacent to the occipital horn here, classical periventricular lesion in the frontal lobe, periventricular lesion in the temporal lobe. Whereas this is not a periventricular lesion. There's a gap between the lesion and the ventricle. These are deep cerebral white matter lesions, which are neither juxtacortical nor juxtaventricular. So these are all not the classical sites of demyelination. These are classical sites for small vessel disease, which regularly we all see. This is the inferior temporal lobe lesions, which can be very close to the temporal horn or might be a little away, but this sort of white matter is not involved in the small vessel disease usually. You can see this involvement of the temporal lobes in CADASIL, but they're mostly anterior temporal and subcortical, but these are a little deep, closer to the ventricles, and another typical or a classical site for involvement in multiple sclerosis. Callososeptal, as I said, involves the corpus callosum and abuts the ependymal surface, another classical site. The cortical lesions have been proved beyond doubt, and that has been included in the dissemination in space criteria in the recent, or in the most recent McDonald's criteria. There are three types of lesions. One is leukocortical, that involves the cortex and the subcortical or juxtacortical white matter. The lesions can be purely intracortical, or the lesions can be sub-PL. This is called the type 3, type 1, type 2, type 3. These are usually identified better on higher Tesla magnets. Not that we can't see them on 1.5. You can sometimes see them on 1.5 also. See, this is a type 1, that is a leukocortical involvement, both gray and white matter. Another leukocortical lesion. This is type 2, purely involving the gray matter. Pretty difficult to identify, but if you have a heavily T1 weighted volume sequence like an SPG or MP-RAGE, sometimes you should be able to demonstrate this intracortical lesions on this. These are best seen on higher Tesla magnets with special sequences called double inversion recovery sequence. These two I have got it from some journals. That's a intracortical lesion. See, this is a leukocortical lesion. This is a phase sensitive inversion recovery. This is a double inversion recovery, where you can see these lesions much better than the standard 1.5 flare. Let me come out of it. Sorry. Yeah. Here is a case where you can see multiple lesions in the brainstem as you go up, in the temporal lobes, and as you still go up, periventricular, subcortical, juxtacortical lesions. In addition, if you see in the right occipital, parieto-occipital area, you can see that whole of the cortex and the sub-PL area is thickened and bright. And if you see it on the contrast, you might see a little amount of sub-PL enhancements. So these are the classical type 3 lesions, which are the sub-PL lesions, which are rare, but have been described on MR. Coming to the spinal cord, posterior fossa lesions, again, the standard rule, it allows to prefer the CSF surfaces. So they can be, so they're along the periphery of the brainstem or centrally close to the aqueduct or the fourth ventricle. Cerebellar peduncles is a common involvement, site of involvement. It can involve white matter tracts or the cranial nerve nuclei tracts, especially the trigeminal tracts. You can see various areas of involvement of the brainstem in different cases here. So that is close to the periphery here. That's close to the periphery here. Again, you can see part of the corticospinal tract is involved, but again, periphery. The superior cerebellar peduncle is involved. This is the involvement in the region of the corticospinal tract here on the left side. If you carefully see, you can see just abutting the fourth ventricle here. This is the site for longitudinal medial longitudinal fasciculus. The middle cerebellar peduncles involvement, which is another classical site. And of course, the cerebellar white matter along with the middle cerebellar peduncles. Here you can see that there is a irregularly linear lesions across the pons, classically the site of the trigeminal tract, where on the contrast you can see that there is subtle enhancement, another classical site of involvement of the posterior fossa in multiple sclerosis. This is a red flag. If you see patchy involvement in the brainstem, which is mostly central, not non-discrete, that is not a classical site for involvement, and it goes with small vessel disease change. Restricted diffusion can occur in acute lesions, but they're not strongly restrict. Most of them show T2 shine through, but you can see some amount of restricted diffusion along the periphery. Here is an example where you can see a restricted diffusion in the facial colliculus. This patient presented acutely with facial nerve involvement, and this is unlikely to be a demyelination and is most likely an infarct. Such a small lesion is unlikely to show restricted diffusion in demyelination. Coming to the typical locations on the cord, only short segments are involved, always less than 2 segments. For example, here you can see small lesion extending from middle of one vertebral body to the middle of other vertebral body. And these are usually involved less than 50% of the cord and cross-section, if you see, like this and this. These are usually wedge-shaped or sometimes rounded. More commonly involves the lateral columns or the posterior columns, but the ventral columns and the central gray matter also can be involved sometimes. When you on a T2 sagittal, if you have a doubt that is there something here or not, the best thing is to do another T2 weighted scan. A pair of eyes are always better than this one. If you can see that the lesion conspicuity increases tremendously by doing a STIR scan, which has been incorporated into the protocol nowadays. These are red flags when you see a cord lesion extending more than 2 vertebral bodies. For example, that's called the longitudinally extending transverse myelitis, for example, in this case, or when it involves more than 50% of the area of the cord, or when it is too symmetrical, here in this case, involving only the ventral dorsal columns, the classical site of subacute combined degeneration, which is due to B12 deficiency in other areas, but commonly in the West, it is due to nitrous oxide abuse. Yeah, there are 2 signs which I was talking, which I trying to deal with in the earlier slide. One is the central vein sign, and the other is peripheral. Other is a PML, that's a peripheral rim enhancing PRL, peripheral rim enhancing lesion. Central vein sign is described on the susceptibility weighted imaging, especially on higher Tesla magnets on 3R mode, where you can see a centrally going vessel through a block. It is exactly in the center, equidistant from the margins, and usually doesn't measure more than 2 millimeters, and it can be seen as a dot if in the other orthogonal plane if you see that, if you happen to scan in the other orthogonal plane. Can we see it on 1.5? Yes, this is an example on our 1.5 machine where I can see a central venous sign in this periventricular juxtaventricular lesion, and here in the centrum semi-well there is another lesion which showing a central vein dot. This is considered relatively specific. However, it can occur in other conditions like neuromyelitis optica spectrum disorders, other autoimmune diseases which are systemic, small vessel disease and Sudhakar syndrome. This is an interesting study where they actually saw how many percentage of lesions are showing central venous sign. These blue dots are all the NMO spectrum of disorders. These red dots are multiple sclerosis. So if they take cutoff as 54%, so if 54% of the lesions are showing this central venous sign, that's more than half of the lesions are showing that. That is more in favor of multiple sclerosis compared to NMO spectrum of disorder, spectrum diseases. This, when you take the 54% as the cutoff value, the accuracy of MR in quantifying them towards multiple sclerosis compared to NMO SD, accuracy increases to 94%. But do we have to do in all cases? Not really, because it hasn't been included in the protocol yet. And to better demonstrate them, you need higher Tesla, and it is another time-consuming sequence to add to the already pre-existing sequences. Probably you may use it in the problem-solving cases. For example, in cases like this, here you can see a periventricular lesion, another periventricular lesion, some periventricular lesion. These are not periventricular, not juxtacortical, whereas here they show some cystic encephalomyelitis changes which favor ischemia than demyelination, and you can see small Walden forks here. So there's a differential between whether is it ischemic lesions or they inflammatory demyelinating lesions. So probably in such cases one might use the central vein sign. Paramagnetic rim enhancing lesion is actually again on the susceptibility weighted imaging, where you can see a hypointense rim around these lesions, which actually represents the iron in the macrophages, iron deposition in the surrounding macrophages, which is indicative of chronic lesions. So this is on a 7 Tesla machine, and I have taken this slide from the one of the Twitter feeds from the Multiple Sclerosis Journal. Coming to the enhancement patterns, the ring enhancement is incomplete ring enhancement is classical for multiple sclerosis or demyelinating lesions. For example, here is a lesion with little amount of edema, and there is no complete ring enhancement. The entire active demyelination sometimes may show an enhancement also, but complete ring enhancement is a red flag, usually like this, which is the case of metastasis, a lot of edema around it, and a lot of edema around it, and a complete ring enhancement, which was taken from Radiopedia. This is a red flag for multiple sclerosis. The criteria for dissemination in time, dissemination in space, you have to identify at least one lesion in typical area. The typical area is in the cord. It can be in the brainstem, or it can be in the adjacent to your ventricle, or a juxtacortical lesion. Dissemination in time, you have an enhancing lesion as well as multiple lesions which were not enhancing actually. This section shows all important lesions, one in the brainstem, one in the inferior temporal lobes close to the ventricles, and a lesion in the optic nerve as well. So if you can see multiple lesions, of which some of them are, one of it is enhancing, so that is another, that satisfies the criteria for dissemination in time. Young patients, as much as 13 years, I have seen this case some time back when I was working in Bahrain. they can be involved with multiple sclerosis, a typical periventricular inferior temporal lobe lesion, juxtaventricular lesion, a cord lesion here. Most important thing is, like, you should do the protocol. We should just struggling to get rid of this pointer. When you do a protocol in these multiple sclerosis, it is important to use the same protocol on the follow-up scans and try to do it on the same machine so that it becomes easier for us to compare. On our packs, we have a comparative tool, in the sense what we do is I can put almost all the 8 scans, eight follow-up scans on the same on different on this layout, and sync them with volumes. If I can do a volume synchronization so that the machine does that for me, and I can go through all those images and compare with the oldest and the newest with interim images in between, which will help me to identify if there are any new lesions, and lesion conspicuity becomes better. If suppose I found a new lesion on the last scan and it was not there on the previous scan, but if I go back to the earlier scan, because of the difference in the technique, or some small lesions may be missed. So this way of comparing with volume syncing would be pretty helpful if you have it on your packs. What are the imaging red flags? When there are multiple lesions, but less than 20% of them are in typical location for MS, or when there are lesions which are too symmetrical, lesions enhancing for more than 3 months are unlikely to be due to multiple sclerosis. If all the lesions are showing enhancement, unlikely to be multiple sclerosis. Diffuse meningeal enhancement, signs of acute hemorrhage, lot of edema around the lesion, or a longitudinally extending transverse myelitis are all red flags. These are the phenotypes of multiple sclerosis. The most common is the relapsing and remitting, where you have attacks with some neurological disability in between, but that remains stable throughout, between the attacks at least. The relapsing and remitting type is basically where initially it starts as the relapsing and remitting, but relapsing and remitting followed by secondary progressive type starts as relapsing and remitting, but at one point it becomes progressive. So in between the attacks, the neurological disability keeps on increasing. So this is the second phenotype. The third phenotype is a primary progressive. You may not see any acute clinical attacks, but patient gradually deteriorates over time. The progressive relapsing type is actually a part of the primary progressive, starts with an acute attack, then gradually the disability increases. In between, there may be some acute attacks. There can be atypical presentations like Marburg's, Felder's, Ballot's concentric sclerosis, or tumefactive demyelination. Clinically isolated syndrome is another entity which has been included in the recent criteria, where the attack should last at least for 24 hours, and there should be signs of subjective and objective signs of a focal or a multifocal CNS involvement, and
Please hold on. I think there's a disconnection from his end. He'll try to re-log in.
cables got disconnected and
yeah, please share your screen and we could go ahead.
sure. Can you see the screen now?
Yes, please go ahead.
Yeah. I was talking about the clinically isolated syndrome. So clinically isolated syndromes can be detected completely by clinically. If there are two areas of involvement clinically, that satisfies the dissemination in space. And if there is one clinical attack followed by MRI showing dissemination in space, then these two are the criteria for dissemination in space. And in such cases, oligoclonal bands, finding oligoclonal bands on the CSF will confirm dissemination in time. So one doesn't need to wait for another attack. This is the most problematic one, radiologically isolated syndrome, when you see lesions in the typical locations for inflammatory demyelination without actually a clinician suspecting it. This is the major problem in diagnosis, actually, when because sometimes people overinterpret things and unnecessarily radiologically isolated syndrome may be brought in. This is a variant of demyelination, tumefactive demyelination, where you can see multiple lesions with edema, which are incompletely enhancing. And you can see that incomplete ring enhancement, some sort of a flame-shaped enhancement, multiple ring enhancing, incomplete ring enhancements, but there's a lot of edema. This patient had a history of malignancy, oral cancer, so meds were also considered, and she was put on steroids. And this patient, actually, an interesting story, when she wanted to move away from this place to close to her relatives. It took 6 weeks for her to go to other hospital and present herself. By the time these have regressed, and which is pretty typical of demyelination when you use steroids. Finally, this was found out to be a tumefactive demyelination. Such tumefactive demyelination, sometimes when they occur without any previous history of demyelinating disease, are called monofocal acute inflammatory demyelination. And if it has got a fulminant core, sometimes then it is called Marburg's variant of multiple sclerosis. Another case of tumefactive demyelination, multiple lesions close to the ventricles, showing incomplete ring enhancements. This is I have taken from Radiopedia, which is called a Ballos concentric sclerosis, which is a progressive variant, where you have alternating areas of demyelination and spared areas of myelination, giving this onion peel appearance. Coming to inflammatory demyelinations, which is a spectrum of conditions which classically involve brain, spinal cord, and optic nerves, just like MS. There is a lot of disorders, of which important ones I would like to draw your attention is the NMO, that's the neuromyelitis optica spectrum disorders, and the MOG antibody diseases. There's a lot of overlap between them. Neuromyelitis optica spectrum disorders involve, when it involves the cord, it's a long segment involvement. For example, in this, you can see a large area of dorsal cord is involved, and this has got actually a biomarker called aquaporin 4 antibodies. This is an autoimmune disease against the aquaporin 4 water channels, which are classically located along the edges of the ventricles, like third and fourth ventricle, lateral ventricles, third ventricle, around the optic nerves, aqueduct, and around the fourth ventricle. These are the classical locations, of which most important location, unusual but classical location, is the area prostema on the dorsal aspect of the medulla, which can cause intractable vomitings. This has been taken from a radiographics article. While I was looking back at the old cases, even though they're not proven, probably these are NMO spectrum disorder, NMO disease, neuromyelitis optica spectrum disorder cases, where I can see a longitudinal extending osteomyelitis with involvement of brain close to the ventricles. Another case where the brainstem is involved along with mammillary bodies and peri-third ventricular areas. The third variety of inflammatory disease, what we commonly call it as ADEM, is MOG antibodies, where this is also has got a specific biomarker for that. It also can involve usually post-viral or post-vaccinal demyelinations, longitudinally extending osteomyelitis, longitudinally extending transverse myelitis, with large areas of brain involved, mainly the subcortical and cortical areas. And if you look at the cord, more than 50% is involved. So coming to the spectrum of these three, actually, if you see the classical areas of involvement in multiple sclerosis, posterior fossa, juxtacortical close to the ventricles, but small discrete lesions. These are little blobby lesions, mostly surrounding the ventricles, brainstem, and optic nerves, whereas MOG antibody disease is actually large lesions in the subcortical areas, cortical areas. Coming to the cord involvement in these three, multiple sclerosis involves less than 3 segments. These two will involve more than 2 segments. One described feature in NMO spectrum disorders is the brightness is like sometimes it can be as bright as a light bulb. That has been described in neuromyelitis optica. And coming to the optic nerve involvement, there can be different segments involved in each. Like multiple sclerosis always involves the central segment, or not the edges, not the proximal, not the distal, but usually the middle areas. NMOSD can be bilateral, but involves posterior, including posterior optic nerves, including the optic chiasm. And the MOG antibody disease usually involves the proximal, including the optic nerve head, and can be bilateral. So the treatment strategies for multiple sclerosis: acute relapses, steroids. And after that, the disease-modifying therapies are given, which is actually a big boon to the MS patients, which can change their quality of life. And third strategy is management of the symptoms affecting the quality of life. And fourth is keeping up to the healthy lifestyles, like managing comorbidities, stopping smoking, etc. One word about the disease-modifying therapies is it is always started after the acute relapse, and these target the immune system dysfunction. The aim of this is to actually prevent future recurrences or reduce the long-term disability or long-term clinically significant disease. Always early treatment offers the best chance of preventing or delaying the morbidity. It has got a potential for sort of a cure, what you can call as a no evidence of disease activity. So that is basically to prevent relapses and disability. And one should not find, to satisfy this criteria, there should not be any relapse or there should not be any progression in the neurological disability. And one should not find any new lesions on MR over a period of time. If one could achieve this with these drugs, that's called no evidence of disease activity. These are actually considered as an investment future, like they're like a small investment plan sort of things, which once you start treating early, you'll find the results of not having long-term disability. The complication for these drugs is, especially with Tysabri or the natalizumab, is PML. I don't have any cases, but this is how a PML looks, just to show you an example. PML is intensely hyperintense on T1 involving the white matter, hyperintense on FLAIR or T2. For the size of the lesion, you hardly find a mass effect. See, the sulci are not effaced, and there is no enhancement. So these are the classical features of PML. Another problem with PML, with the Tysabri-induced PML, is that once you stop the disease-modifying treatment, there is what is called an iris can occur, that is immune reconstruction inflammatory syndrome. So there can be deterioration after the withdrawal. Actually, there may be a rebound phenomenon and a further progression of the disease. So when will you give contrast? We all know that when you see lesion suspicious for, on the first scan, when you see lesion suspicious for demyelination, you might give a contrast just to see an enhancing lesion. Or you see multiple lesions, you want to differentiate from other lesions like metastasis, you give contrast. And these are the other indications where if you want to predict the future activity or future disease progression, or if suppose and some specific phenotypes where you're considering disease modifying treatments, no MR was available in the last 1 year, probably you might do a new MR with giving contrast. While monitoring the disease, not always you do the contrast scans. It depends when the actually neurologist wants a contrast scan, they have to specify clearly. It's mainly to see whether there's any clinical suspicion of a current disease while on active treatment, or if there is and to detect any subclinical activities. And when the patient is on a low efficacy modifying disease modifying drugs, in the first 2 years when you do the study, because it is on a low efficacy, usually people give contrast just to see if there's any new disease, enhancing active disease, just to check that it is under control. And when you're routinely monitoring it, normally we don't give contrast, we just see if there's any new lesions have occurred or not. And for PML screening, you don't need contrast. Okay, these are the protocols, standard protocols. You use 3 mm T2 axials. If you have a 3D flare, nothing like it. Best is to perform a 3D flare or a 2D flare in sagittal and axial planes and give post contrast after this. Especially in MS, because lesions need time to enhance, you can give contrast to start with and go with this protocol because that's not going to affect T2 at all. They might contrast might increase the lesion conspicuity and the flare imaging. When you're monitoring the effectiveness of treatment, don't give contrast unless neurologist wants it. For PML, no contrast is needed. Spinal cord, always do 2 T2 weighted imaging, sagittals, and a T1 weighted sagittal. Either a T2 or a medic or a gradient axial is advised, which should be 5 millimeters or less. And you don't need to do a pre-contrast scans. Actually, it can be followed with a post-contrast brain. You can just do these 3 sequences. The problem mainly is with clinicians, it is over-reliance on MR. With nowadays with plummeting clinical medicine, they're not sure about the clinical aspects, so they try to rely more on MR. Whereas from the radiologist side, over-reporting white matter lesions, young patient, you see a white matter lesion, you try to fit them into this criteria rather than carefully seeing whether they will fit into that criteria or not. And what radiologists should remember is the imaging is not actually aimed at to differentiate MS from other white matter lesions. It will help, but it will not, the imaging is not done to do that. The imaging is done to see which one is going to develop MS in future by looking at those sites. And clinicians also should understand that they shouldn't ask radiologists whether it's an MS or not. They should ask whether the radiological findings support the diagnosis of MS or not. So some take-home messages. Imaging helps to reinforce the clinical diagnosis. It is not an alternative to the clinical diagnosis. Cortical lesions are pretty common. If you start using 3 Tesla or more, you keep seeing them. Classic location of the plaques, always remember that MS loves CSF, so they tend to move closer to the CSF surfaces or along a known white matter tract. The central venous signs, or a CVS, or a PRL, that's peripheral rim enhancing lesions, use them as a problem-solving tools if you have a higher strength magnet, but don't get carried away by them. And in your report, never say the features are diagnostic of MS, nor if you see multiple lesions increase in the number lesion load, never say progressive disease in the report. The progressive disease is a clinical term. It is actually intended to tell that there is a neurological disability progression, not the imaging progression. So if you use that term, and it will be difficult for the neurologist to explain to the patient. If suppose neurologist doesn't find if it's neurologically stable, they won't classify it as a progressive disease, even though there are new lesions on MR. So you should never use that term in the report. It's a clinical term. And always be consistent with your protocols and try to do it on the same machine so that you can compare apples with apples. And follow-up scans, always ask the clinician what they exactly want to know. They want to know new lesions where you don't give contrast, or they want to know new and active lesion where you will give contrast. And the disease-modifying treatments are mainly intended to maximize the brain health, which are actually an investment for future. And you should be aware of the PML. These are the references. Thank you.
Thank you, Sudhakar. That's a wonderful presentation, very comprehensive, both clinical and radiological aspects. We have neurologists and neuroradiologists as well as general radiologists in the audience today. Dr. Subhash Kaul is there, Dr. Atik, any of the neurologists. You could ask any questions or your comments, please.